All right, guys, we're going to get started. Thank you so much for joining us here tonight. My name is Tatum. I'm the IVF coordinator, Fertility and Endocrine.
And I'm Lauren. I am the nurse practitioner here at Fertility and Endocrine Associates.
So kind of our goals tonight are just to talk about IVF, whether with the procedures of everything and the process of going through our clinic. So kind of just first, what is IVF?
So IVF, or in vitro fertilization, is the process of removing eggs from the ovary and inseminating them outside of the body and then growing them in a lab till they get to a certain stage and replacing them into the uterus to create a pregnancy.
From there, we do have several processes during the IVF process. We do batching IVF here. That means that for 1 week, every single month, we'll do an IVF retrieval. That's when our embryologists and our whole team get together. Lauren, can you kind of talk about what our week-to-week baselines and retrievals look like?
So each person, when they come in and they get their specific set of medications and kind of your tailored protocol, you will get a calendar. And this is literally a physical calendar that has each one of your appointments on it, whether it is for an ultrasound, labs, FDA labs for yourself and your partner if you need them. But the initial ultrasound is called a baseline. And the baseline is literally just to get us a quiet uterus, quiet ovaries, and make sure we have a good starting point. During that baseline, after that, we will let you know when to go ahead and start your medications. Everybody's medications are different, but they are usually composed of three basic types of medications. One, to cause your ovaries to start making extra eggs instead of just that one egg that a woman usually ovulates per month. We actually recruit more eggs. Each person has 10 to 20 eggs on each side. And instead of letting those die off and reabsorb like they do every month, instead of just that one ovulating, we actually get more of them to grow, and that's how we get all of our eggs. So with that medication, you will have an ultrasound every 2 to 3 days to see how the eggs are growing, and we know based on size when is the best time to have you go ahead and ovulate, and we get those eggs out during the retrieval procedure.
There are several patients that can definitely go through IVF. We always kind of go off their candidacy as well. Who's a good candidate for IVF?
So really anyone can do IVF, but some of the really good candidates that we see kind of often, or would be someone that would be helped by IVF, can be somebody over the age of 35. After the age of 35, you have a increase in the number of abnormal eggs. So with IVF, we get more eggs at one time, and it's more likely that you get a healthy embryo instead of an abnormal embryo. You can also have people that have maybe male factor infertility and may have difficulty, the sperm may have difficulty actually getting through the egg to fertilize. We take care of that by puncturing a egg and actually putting one sperm into each egg. Some other ideas are genetic factors, people that have maybe the gene for cystic fibrosis, or they know they have the BRCA gene and they want to prevent that from being passed on to offspring. Recurrent pregnancy loss, we can have people that go through IVF for that as well.
Awesome. Thank you. So if someone was interested in doing IVF, what would be their next steps between contacting the office and kind of going through the process?
We have an initial consult that we just call a new patient appointment, and most of that is where we actually go through and try to figure out what is the cause. We don't always know a cause that you need for IVF, but generally we can look through some basic things. We can look through, do we have eggs available? Is the sperm at a certain quality? Do we have some sort of uterine factor or tubal factor that we are trying to work around? So that is kind of that initial workup that we may kind of investigate different things. But after that, it really is based on some certain laboratory values and an initial ultrasound that tells us what your protocol might be. That usually comes with that baseline or that IVF consult that we determine that. But that new patient consult really comes with mostly labs to check on some hormone levels. We check your thyroid, we check a prolactin level. We may also look at a lot of times what's called an AMH or an anti-Mullerian hormone. That is some supportive cells that are around the eggs. And based on that, we can tell what your ovarian reserve is like. So lower ovarian reserve or higher ovarian reserve tells us which medications and how much of the medications to use.
Okay. So kind of in the beginning, we're starting at that new patient consult and the provider is guiding us with lab work and just next steps. If IVF is advised, then we're going to more of an IVF consult to figure out, kind of get a more understanding what the IVF process is. A lot of times after that, I'm happy to meet with you guys to talk about a financial consult, look at your insurance, look at your benefits and coverage with that, along with talk about loans, loan servicers, and ways that we can finance IVF through that process. One of the things I always like to tell patients too, just with the IVF process, we do have those medications that Lauren mentioned earlier. So typically there's 3 medications. One of them is going to be that follicle stimulating hormone, FSH. That's to grow all those eggs. The other one is an antagonist. That's to keep all those eggs in so you guys don't ovulate too early. And that third one is a trigger shot that will let us allow you to ovulate at that perfect time for the retrieval week. Those are another things to kind of factor in with those IVF pricing. And I'm happy to help get some assistance for you guys too. Let's see. Anything you want to add on at the moment?
I don't think so. Yeah.
Um,
Oh, yeah. Okay. So after you have a retrieval, that is actually where we go in and remove the eggs from the ovary. That's after that growth period where you're on the medications. That's usually about 8 to 12 days. You're in our office fairly commonly that week and a half. You're here for an ultrasound every 2 to 3 days. We will know kind of exactly when you need to have that retrieval done. That process is done on the other side of our office where we have an area to do kind of more of a surgical type procedure. We have anesthesia that comes into the office and you would be given sedation. It's not general anesthesia, so you're not intubated. You're actually breathing on your own, but you are completely asleep and unaware. So after and during that retrieval, you're monitored quite closely. You'll see me during that as well. I will either be in the retrieval, helping, assisting with that, or Tatum will be, and one of us is always monitoring you afterwards. You'll hang out with us for about an hour while you recover from that anesthesia. And then you get to go home and just rest for about 2 days. After that, you pretty much are back to normal, maybe a little bloated and swollen, but feeling most of the time pretty good. And you will follow up with us in about a week or 2 to do another ultrasound and make sure those ovaries are back to baseline. While you are figuring that part out and resting at home, our embryologist is working with your eggs and your sperm. The eggs, after they come out of your body, which that is done with a transvaginal ultrasound, very similar to what we use when we're monitoring you. There's also a needle guide, and we use just a suction mechanism and a needle to aspirate that fluid out. And usually 1 egg comes out from each follicle that we have. So as we do that, we send those back to the embryologist, and she will get to work on that. We have 2 embryologists that switch out here at the office, and they will take 1 sperm for each egg and inject that. And we know fertilization by the next day. So after fertilization happens, we put all of the fertilized eggs into an incubator. They kind of hang out in an incubator that they may be in a dish like this, or they may be in another little contraption. But we keep them in the dark. We keep them at a very consistent pH. And we keep them at a really consistent temperature, right at body temperature. And we make everything very similar to what it would be like in a fallopian tube. And so those fertilized eggs start to grow and they start to multiply those cells. And when they reach a certain stage called a blastocyst, which is usually about 5 to 6 days after everything is taken place, we will have the opportunity to either biopsy them by taking 3 to 5 cells from that trophectoderm or what becomes the placenta, and we can send those off to a specialty lab, and they're able to do a genetic profile of each embryo, and we're able to see what embryos are normal. So if they're euploid, that means they have 46 chromosomes, which is what a human being should have. Or if they have a few more or a few less, are they going to be able to make a baby or not, basically. So if someone actually does that testing, it's called PGT testing, they have a higher chance of an implantation and a pregnancy. This is especially helpful after age like 35, when you have more abnormal eggs than you would if it's before 35. If you do PGT testing, whenever you put that euploid or normal embryo back into that perfect uterus, you have about a 65% chance of pregnancy, which is, if you think about a normal couple each month, they have about a 20% chance of pregnancy. So you get much higher chances than you would typically. There are also people that choose not to do genetic testing, which is fine. Depending on age, if you are below age 35, you have to have about 50-50 chance with an untested embryo. And if you're above 35, it's about a 30 to 40% chance. So those are some specific things that really make IVF much more likely to work.
And then you said, so each month we're growing about 10 to 20 eggs for the IVF process. How many of those eggs would actually become a mature embryo?
So with those eggs, it really is determined by if they are normal and how they fertilize and how they progress. Many of them don't make it to that blastocyst stage, but if you started out with 10 to 20 eggs, it's usually about 30% make it to blastocyst. So if you had 10 eggs, you could expect about 3 blastocysts to make it, and if you had 20 eggs, you could expect about 6. So you have 3 to 6 typically.
Okay. All right. Anything else you want to add on?
I don't think so.
We'll go ahead and open this time up to questions. Does anyone have any questions? You guys are welcome to type in the little box and it'll pop up on our screen. Or you're also welcome to unmute yourself either way.
I did collect a couple things from our embryologist just for this kind of situation to kind of show you what we actually work with or they work with each day. Our materials are pretty typical, something that most women experience at the OBGYN, but the embryologist did give me a sample catheter. So this is what that little catheter looks like when you are having that embryo replaced. It's very small, it's very flexible, kind of like a piece of cooked spaghetti. And that is just put through the cervix, and that little catheter has that embryo in it. And we can actually switch out those and then just thread the catheter back through, and it goes right into your uterus that we have prepped to make exactly correct. Okay. Here's also a cane that they use. This is what the embryos are stored in that freezer, basically. This is typically one set of embryos will be in this, so a family's set of embryos. And this is what a straw that the actual little embryos go into. And then they're loaded into here. And then they are frozen. and stored here. You'll have multiple layers of name, date of birth, all those things, so nothing can get confused. And there's also a couple of other ways we identify them. A lot of times there will be a color-coded piece of tape, basically, that's on each layer so that nobody's embryos can get mismatched. You get any common questions, Tatum?
I feel like we answered about most of those. A lot of my questions deal with how do I inject my medications? A lot of the times before your IVF cycle, I'll go over that with you. We'll actually do hands-on training with the little practice drugs. Basically, it'll look the same exact as your IVF medications at home. We'll practice those medications. Those typically go in two different spots. One's going to be your abdomen, just in your belly. We call that a subcutaneous injection. The second one would also be intramuscular, which is usually just in the back of your hip. You'll either do medication teaching with me or Lauren, and we go over that entire process until you're comfortable with that. We also send plenty of resources on videos of how to do your medications. We have several links on our website as well with Dr. Kraus. She goes over the entire IVF process, what the medications do in your body. So it's always nice to have those resources.
We did, one thing that people ask is what happens once I get pregnant, because that is the goal of this. And it usually is after a transfer, whether you have a tested embryo or an untested embryo. 9 days later, we do 9 or 10 days later, we do a pregnancy test after that, and usually repeat that in 48 hours to see how our numbers are rising. And after that, we do an ultrasound, usually 6 and 8 weeks, sometimes 10 weeks, and you get off to your OB.
So that's kind of our goal is have you come in for a consult, get you situated with IVF. We'll do an embryo transfer, and the goal is to hopefully have you graduate right around 10 weeks of pregnancy.
Yeah, so it is not always quick, but and not always easy, but it is definitely something that we take care of quite a bit. Well, I don't think we have any questions, so yeah, it was nice to talk, and hopefully you got something out of it.
Thank you so much for your time. Have a good night.
Bye.